Hi, everybody. My name is Amy, and I so appreciate everyone being on the call tonight. And my goal of this meeting is really just to share with you the current data as it focuses around women's heart health, and to provide all of us with a message of hope and also a message of action, because I really think it's time that we change the current statistics. So first, I'd like to introduce myself. I am the director of the Heart Attack and Stroke Prevention Center in Spokane, Washington. I am a clinical associate professor at the Washington State University College of Medicine. I am assistant professor at the University of Kentucky College of Dentistry and adjunct professor at Texas Tech University School of Nursing. And although that may look like a robust sort of agenda, it's all for one purpose. It's to bring prevention to every area that we can possibly touch for individual providers who affect vascular inflammation. And so working in partnership with these three colleges allows us to really make a difference in how people are treated from a cardiovascular standpoint. And I'm also the co-founder of the Doneen method with Dr. Bradley Bale, who's been a partner of mine, and together we've really aimed to eradicate heart disease as the number one cause of death and disability by the year 2020. My most important accomplishment is this slide. I am the proud mother of these three children. Two are in college now. Our oldest, Sydney, is a senior at University of Puget Sound. Devin is a sophomore at Western Washington University, and Sophie's still in high school. She's a junior. One of my biggest goals is to make sure my children like each other when they're adults. And they so far so good on that. We have a lot of fun together as a family. This is my husband, Darren. One of my hobbies is I am a passionate runner. I enjoy it very much. It's fun for me to get out and enjoy the quiet and the mindfulness. So that's a little bit about me. One of my favorite authors, poets, academician is Dr. Maya Angelou. And one of her many quotes that I often talk about is this one: success is liking yourself, liking what you do, and liking how you do it. So I appreciate her definition of success. And I think we all struggle to like ourselves just as we are, with all of our benefits and all of our challenges. But I certainly work on that all the time, and I really love what I do, and I like how I've had the opportunity to do it. So I feel successful in life because of that. So I appreciate her definition. The agenda tonight is the following. I want to first bring to you the facts. What are the statistics around heart disease, and have they changed? Are we still sort of in that platform of 1 out of 3 of us may suffer an event in our lifetime? So I want to go over the current facts. And then I want to cover with you something I call red flags. And red flags are opportunities to realize that we personally might have a lifetime risk for heart attack and stroke. And then I want to tell you, what are you going to do about it? What can we do? In order to do that, we need to understand what causes a heart attack. And then I want to touch briefly on inflammation, which is the real key to know if we're at risk for an event or not. And then I want to give you 10 quick things that you can implement tomorrow that will make your heart happy, and that you'll be healthier come Friday than you were on Thursday. So I really want to leave you tonight with some action items. I am going to speak for 1 hour, and I welcome you to email me, call me, reach out to me if you have any follow-up questions after the talk. We must, as women, open our eyes to this disease. We should not be silent. I want us to appreciate the significance of women and heart disease. Heart disease is the #1 killer of women in the United States, claiming more lives than all forms of cancer combined. 1 out of 3 of these beautiful women will suffer a cardiovascular event in their lifetime unless we do something different. Matter of fact, heart attacks occur every 25 seconds in this country, and every minute, someone is dying from one. 1 out of 3 of these beautiful women may suffer a heart attack in her lifetime. Every 40 seconds, someone in the United States has a stroke. Women have the highest rate of recidivistic stroke risk, and that data is strongest in young women. So young women who have a stroke are the highest risk demographic to have another one, and that's not a statistic any of us want to support. 64% of women who die suddenly of a heart attack have no idea that they're walking around with heart disease. The death rate among women ages 35 to 44 has been increasing by 1.3% per year since 1997. We aim to change this. Dr. McSweeney in 2003 did a very important study. She took women who were in the hospital with a heart attack and she asked them 2 very important questions. She said, "What did you feel like a month before you had your heart attack?" And she also asked them, "What did you feel at the time of your heart attack?" So what I want to point out are the symptoms that were most common 1 month prior to suffering a heart attack. They included things like, I wasn't feeling very well. I was so tired. Matter of fact, I wasn't sleeping well and I was anxious. I didn't really know why, but I felt very anxious. At the time of a heart attack, women complained of shortness of breath, abdominal pain, and sweating. Why do I point those out? I point those out because they don't fit the normal protocols that you see in print, that you hear about on the television, that many of our male heart attack patients suffer, like the crushing chest pain, the left arm pain, the jaw pain that we hear about. Not to say women can't have those, but what I want to point out is so often these types of symptoms, fatigue, sleep disturbance, or unexplained anxiety, are validated away, inappropriately so, due to things called life, like working moms or perimenopause or menopause symptoms, or even just fatigue and exhaustion. And at the time, shortness of breath, abdominal pain, and sweating, this is part of the reason, and this may be my personal bias, why women tend to present to the emergency room later. And even our anatomy can suffer less of an assault than a man who has a larger heart and larger vessels. So you put all that together, lack of recognition of symptoms, explaining the symptoms away, not presenting quick enough to the emergency room, and you can start to appreciate the grandness of this situation that we're in right now. It's an honor for me to educate women about heart disease, and I love this quote. It says this: "Remember, ladies, Ginger Rogers did everything Fred Astaire did, but she did it backwards and in high heels." So I think a lot of times we need to just kind of stand up and recognize our uniqueness and celebrate that for sure. So where are we right now with our campaign, and why do these statistics actually remain? I mean, where are we with the red dress campaign, which I deeply respect? I want to say this, that when you look at breast cancer, and I have a huge respect for breast cancer, obviously, but they've had a tremendous head start on us as far as the red dress campaign. I mean, for heaven's sakes, breast cancer has the NFL. The NFL talks about breast cancer through the entire month of October. They wear pink shoes, pink gloves, pink headbands. They have it on the footballs. They have it on the field. So breast cancer has gained a lot of traction, and I don't want to take anything away from that, but I want to say, where are we with our sponsorship? And when you really look at women in heart disease, we have things like runway shows and red dress parties, and even Coke. Diet Coke, for that matter, is a proud sponsor of the women's heart health agenda. And that's really, with all due respect, not a sponsor that I really want representing heart disease, Because when you look at even the data with soda, diet or regular, diet soda actually increases vascular events by 50%. That's one or more servings per day. So one of the first things I do with patients is say, no longer are you going to drink soda, ever. Each additional serving of soda per day, diet or regular, was associated with a 19% increased risk of heart disease. So ladies, do not have it in your house. Do not buy it at the store. Do not give it to your kids. There are lots of other things like water, and even coffee is great, but not soda. So how do we know if we might have increased risk for heart disease? How might we know that? Well, one thing to recognize is that there's a lot of opportunities to say, hey, maybe I am vulnerable. Maybe I might have a condition that I didn't ask for, I certainly didn't cause, but yet I'm dealing with it. Does that give me the opportunity to say later in life, I might have an increased risk of an event? And I would like to argue that if any of you on the call, or a friend or family member or someone you care about has any of these red flags, you need to understand that there's an increased association with events. And red flags are different than root causes in that if we fix the red flag, it doesn't mean that the risk may go away, but a red flag is an opportunity to go get checked out. So what I want to do now is cover some of these red flags just so that we all appreciate how vulnerable we are. So chronic inflammation is one of them. If anyone's dealing with chronic inflammation of any kind, autoimmune being the most culprative, we are at risk if we have an autoimmune disease of about a 20% increased lifetime risk of cardiovascular disease events. So when you look at the data, it overall shows a significant 20% increased risk of heart disease or diabetes with a chronic inflammatory disease. What are those diseases? They're things like psoriasis, colitis, systemic vasculitis, Crohn's disease, all of these types of autoimmune diseases, rheumatoid arthritis, of course, which we're going to cover in a second. All of these place us at increased risk for not only heart attacks in our lifetime, but type 2 diabetes. Rheumatoid arthritis is a really significant factor. Matter of fact, a patient who struggles with rheumatoid arthritis is just as likely to die from a heart attack as a diabetic individual. So if you have someone with rheumatoid arthritis, it's a multifactorial situation. There's a lot of pain associated with it. There's depression associated with it. There's poor sleep habits. There's medication that also might increase risk, like steroid use for inflammation, or non-steroidal anti-inflammatories like ibuprofen increase risk. So it's not even just the diagnosis of the RA, it's the treatment and the lifestyle that often surrounds it that place us at a really vulnerable lifetime risk. So I really like to take care of my rheumatoid arthritic patients. What about systemic lupus erythematosus? Lupus is a systemic disease. Oftentimes, you'll see what they call the butterfly rash on the face, but it's really a systemic inflammatory situation that places women at a twofold increased risk of dealing with heart disease in their lifetime. So again, these people need very appropriate preventative care. Psoriasis, severe psoriasis is associated with a 50% increased risk of death and as many as 5 years of lost life explained by cardiovascular disease, infection, and cancer. Younger patients with severe psoriasis have a 2.5-fold higher risk of dying of a cardiovascular event in their lifetime. I have the picture of Miss Kim Kardashian, who for younger women out there has been I think, a voice to let people know that psoriasis can, number one, happen to everybody. What she may or may not know is that it increases her risk of a heart attack significantly by 2.5-fold. What about migraines? Migraines are a problem, obviously, for overall health and wellness. But what we do know is middle-aged females who have migraines with aura. That means there's some sort of prodrome, like a nausea or visual disturbances, where people know, oh my gosh, I'm going to get a migraine. They have those very recognizable pre-symptoms to the headache. That diagnosis of a migraine, those individual women are at they have a 90% increased risk of having a stroke late in their life. Why? We're not really sure. Is it the pathology of the migraine? Is it again like the RA situation where they've had a lifetime of treatments such as ibuprofen and Advil and things that also increase risk? Is it that there's poor sleep habits? Is there an association with depression? It's really, again, multifactorial. It does not mean that women with migraines are going to have a stroke. It doesn't mean that at all. It just means they need to get the attention they need from a preventative standpoint so that they're protected throughout their life. Polycystic ovarian syndrome is another one that's unique to women. It's associated with an increased risk of subclinical atherosclerotic vascular disease. It's also associated with things like obesity, insulin resistance, diabetes, and lipid abnormalities. Women with polycystic ovarian syndrome are 3 times more likely to have heart disease throughout their lifetime, which obviously is a very big deal. This study suggests that women in their 20s who are dealing with PCOS who are at increased risk for the development of subclinical plaque even before they're 50 years old. So we really need to respect the fact that it's not just cysts on the ovaries, it's giving an opportunity to assess that individual for their cardiovascular risk and wrap them in a blanket of prevention throughout their whole lifetime. Preeclampsia is something that many women suffer during pregnancy. It's associated with sudden fluid retention during the pregnancy, protein in the urine, high blood pressure with pregnancy. If unaddressed, it can affect both the life health of the baby and the mother. But preeclampsia also is a warning sign. And I really take this to heart. They've shown that women who experience preeclampsia during pregnancy have a double the risk of heart disease or stroke 10 to 12 years post that pregnancy. Why is that important? Because women forget that they had preeclampsia because when the baby is born, the preeclamptic symptoms go away. And now the child is 10 years old and they're in third grade. And all of a sudden, this poor mom who's enjoying good health and being a young mother suffers a stroke or a heart attack. And it could have been a clue 10 years ago that she deserves some attention from a prevention standpoint. It's also associated with venous clotting 4 to 5 years after the pregnancy. Matter of fact, when this study was published, the authors said preeclamptic women need a full cardiovascular risk assessment 3 to 6 months after delivery. And usually that's not done. And I would like to say any woman that's dealt with this deserves a full preventative workup. A couple more, gestational diabetes is linked to a 66% increased risk of future cardiovascular disease over a 12-year time period. These women need more aggressive screening post-pregnancy for things like diabetes, cholesterol, and blood pressure. I often say to women, it's not a matter of if you're going to get type 2 diabetes, it's a matter of when and how early can we diagnose you with insulin resistance so that diabetes doesn't occur. Preterm birth and maternal heart disease. This one was just published this week in JAMA. It was a population-based cohort study using over 700,000 women ages 16 to 59. And they looked at the women who had preterm birth and low birth weight babies, showing a 66% increased risk of heart disease, and they were followed out for about 16 years. When you look at the Kaplan-Meier curve, what I want to show you is just this top line here. And those are the women that dealt with a preterm birth pregnancy. And the SGA stands for severely small for gestational age. So if the baby was born prematurely and severely small for their gestational age, you can see the risk of a heart attack in their lifetime is, or over the next 14 years, is up to almost 17% higher than those women who had a normal pregnancy with a normal weight child. Just if none of this applies to you, just right now while I'm talking, check your heart rate. You can check your pulse on your neck, or you can check it just above your thumb on your wrist, on the inside of your wrist. And if your resting heart rate is over 76 beats per minute versus less than 62 beats per minute, you have about a 26% increased risk of a heart attack in your lifetime. It becomes more significant the younger you are with a higher heart rate. It's predictive in all ethnic groups, and it's independent of physical activity. And the take home here is there's usually a reason that you have a higher resting pulse. And it's not always that maybe you just need to improve your fitness. A higher heart rate, especially for younger women, is a definite risk factor. How about caregivers? I really feel for caregivers because I think they're often ignored in Western medicine, at least in a really fast paced cardiovascular clinic or general family practice clinic. But they looked at couples who were caring for a loved one at home with cancer, and they were really evaluating the risk of heart attack or stroke. And they divided it up into men and women who were the caregivers. And I want to just break it down very simply. They divided the outcomes into being a caregiver for less than 1 year, 1 to 4 years, or over 5 years. And for women, there was a 17% increased risk of a heart attack between the 1 and 4 year time period. And the one that really gets my attention is the stroke. 36% increased risk of a stroke when you were caring for a loved one at home for over 5 years. And what I want to point out, a lot of times it's that those caregivers are not keeping their own medical appointments. Whoops, someone's not muted. Carol, if you can take care of that for me, please. Um, um, for women that are also long-term caregivers, 5 years is past the point that people are churches are bringing food over. There's care providers available. They're missing perhaps their dental appointments. So really pay attention to those caregivers. This is a new one that was recently published this week as well, and it looked at a crossover between cardiovascular disease and breast cancer and how the risk factors for both intersect with each other. So when you look at the commonalities between cardiovascular disease and breast cancer, you have things like age, diet, family history, alcohol intake, hormone replacement therapy, struggling with weight, physical activity, tobacco use. There's a lot of crossover they're really looking at, and this was a statement by the American Heart Association. When you look at risk of cardiovascular disease and risk of breast cancer, and you go down the line, you see how there's a lot of similarities. Healthy diet brings down both, whereas a traditional Western diet increases your risk of both disease states. One interesting fact that I think is early menopause. So women that go into menopause early have an increased risk of cardiovascular disease and yet are showing a decreased risk of breast cancer. With that being said, hormone replacement therapy of any type, topical, oral, pellets, any type of hormone replacement therapy has the possibility, doesn't mean it that women can't have it. There's lots of reasons hormone replacement therapy is necessary for bone health, for quality of life, all of that. However, there's a possibility that it's not a benign recommendation in either the world of breast cancer or heart disease. So again, if someone's on hormone replacement therapy, especially those women who are in early menopause, I really want to be respectful that they need a full cardiovascular workup and careful care for monitoring for breast cancer. So what if someone has some red flags, or even perhaps as I've been talking this evening, what if you have a red flag, or your sister or your mother or your aunt or your neighbor or your friend or your cousin? What do you do now? You say, Amy, my goodness, I have migraines with aura. What do I do now? Well, I would argue the first step is to understand what causes a heart attack. Because if we understand what causes a heart attack, we're going to appreciate what we need to do about it. So let's talk about that for just one moment. I want to quote Nelson Mandela on this. He said, "Education is the most powerful weapon which you can use to change the world." Sometimes our world is our kitchen table. Sometimes our world is our office. Sometimes our world is our extended family. Whoever it is that you have the opportunity to educate, starting with yourself, please do it, because I think this disease is only going to change if we tackle it one person at a time. And I really respect all of you on the call who are going to take little tidbits of this and share it with someone tomorrow. And I really appreciate that. So, what really causes a heart attack or stroke? What really causes it? So, what I want to tell you is plaque buildup in the arteries, as you can see by this cross sectional evaluation. You don't feel it. The body starts to develop fatty streaks in the wall of the artery. Cholesterol gets through this wall. It's called the endothelial wall, and it gets trapped in here. And when it does that, it begins to oxidize or simply break down. And all of a sudden, we start to develop an inflammatory cascade in the wall of the artery. No one feels it at this stage, and that's why it's so sneaky. So plaque looks like this for perhaps years. And if it's going on in your arteries, unless you've gone in and looked for it, you're not going to know it's there. Most of the time, matter of fact, 64% of the time in women, we only know about it when this happens. And that is, you get a plaque that has been developing over time that ruptures through the artery wall, and the body says, don't worry, we're going to fix that for you, and can send in all kinds of clotting factors and form a clot, or a fancy name for that is called a thrombus. And if that thrombus blocks the flow of blood in the heart, we're going to call it a heart attack. If it blocks the flow of blood in the brain, we're going to call it a stroke. So I'm going to show you a really quick video that illustrates why someone is so caught off guard when they have a heart attack. People often say, Amy, I don't understand why Aunt Sally was fine at Thanksgiving and she had a stroke before Christmas. Or my cousin Julie, she was fine yesterday and she had a heart attack last night. Could I have known that? Perhaps not, because the plaque rupture and the thrombus are very, very quick oftentimes, and unpredicted until they happen. So I want to play this very short video with you. And let me turn off the sound because we don't need that. And I'm going to talk our way through it. So this is an illustration of a cross section of an artery. And you can see here how cholesterol gets in through the artery wall, and it gets trapped by these white blood cells that trap them. They trap that oxidized LDL. They form foam cells, and they can cause a disruption in that artery wall. And in seconds, the body sends in red blood cells, white blood cells, platelets, basically forming a clot that blocks blood flow around that area. And that is called a heart attack. So you can appreciate how that can happen in a very quick and unpredicted fashion. So if the clot happens here, and the blood flow around it is restricted, that muscle tissue is going to be damaged, and that's what's called a heart attack. If the clot happens here and the surrounding tissue of the brain doesn't get blood flow, we're going to call it a stroke. But I want you to appreciate that we have 60,000 miles of highways in our body. So if, on that same note, if you have a heart attack and we place a stent, or we even open it with something called an angioplasty, or we really fancily replace this whole artery with a bypass, realize that your plaque is all over your body. And so the risk of dealing with a subsequent event is high unless we pause and figure out, why did you develop plaque in the first place? So I want you to think a little bit more globally on that. So what does atherosclerosis, or plaque in the artery wall, look like before a heart attack or stroke? Well, it looks like us tonight. No one has ever told me, Amy, you know what? I'm going to have a heart attack next Saturday because I'm wide open. I don't have to take the kids to gym. I don't have to go to the soccer field. I'm like wide open. I'm going to have a heart attack then, just get it out of the way. Everyone wakes up every day without intending that they're going to have a heart attack or stroke, which is the way it should be. But that's part of the problem with this disease. We don't expect it's going to happen to us until it does, because the plaque is so silent until there's a problem. And that's what we aim to change. So, how can we find it when it's here? How can we do that? So, I want to talk to you about that opportunity, number one. And ladies, it is our responsibility as our own healthcare providers, as our own queen of our body, to say, I want to know if I have this. Because I got to tell you a secret, insurance companies don't care if you have this or not. They are only going to care if it does that, and then they'll treat you. So when I'm talking about finding it at this stage, you're going to have to ask for testing, and I'm going to explain why. Traditional medicine, Western medicine as it stands, even in 2018, and I mean even fancy cardiology practices, are focused on blood flow. How much blood flow is through the lumen, that's the opening of the artery, is happening? How much blood flow? And things that look at blood flow, if you can see the field of view, is that tube, the amount of blood flow. And you know now that the plaque hides out here. So if your field of view is here, you're going to miss it, aren't you? And tests that are luminology tests, those are things that are very popular. Stress testing, duplex scanning of the carotids, which look at blood flow of the carotids, things like angiograms. And they're really important tests if you have symptoms and you're worried about a blockage. But if you're trying to find plaque here, you're not going to find it by doing a stress test. Matter of fact, if you take a stress test and you pass it, all we can say is that you didn't have a 70% blocked artery at the time of the stress test. And the challenge is that 86% of heart attacks occur in vessels that are less than 70% blocked at the time of the test. So one thing that we have focused on over the last 17 years is the study and focus and science and imaging of the plaque itself. So we actually focus here, and we call it arteriology because it's a science and study of the artery wall. And we do tests all the time that are available to you, things like carotid IMT testing, coronary calcium testing. Those are all available to you at your fingertips, and they're aimed to find plaque that you can't feel. And wouldn't it be nice to know if you have plaque? And if you do have plaque, what I want to tell you is we have proven with our colleagues at Johns Hopkins that we can identify and we can stabilize that plaque. So the time is now, ladies. We can find plaque before a heart attack or stroke. We do not need to be the 64% of women who find out they have plaque when it's ruptured and you have a blood clot to prove it. We can do something different. Matter of fact, Inland Imaging right here in Spokane, Washington, through the month of February, does a scan called a coronary scan to look for any calcium in the arteries for $100. You just need to ask your doctor and say, and your nurse practitioner, and say, I'd like to get a coronary calcium scan. And they might say, well, why? And you say, well, I have a family history, or I have a red flag. I had preeclampsia, or I had gestational diabetes, or how about I just want to know? And if you know you have calcium, it's a big deal. Matter of fact, we had a very famous person lately get coronary calcium scores published, and it happens to be the president of the United States, and he had a positive coronary score, which means he is at risk for a cardiovascular event. So if you have a positive score, anything above 0, it's a big deal. It's treatable, but it's a big deal. Another test that we've used for a long time, and it's been backed by the American Heart Association since the year 2000, so now 17 years, we've had the ability with an ultrasound, and it's different than a duplex, but to measure the artery wall. And we actually look for plaque, as you can see here. We look for the thickness of the artery, and we can even give you an age match and say, well, my goodness, you may be 45 years old, but your arteries look like a 60-year-old. Let's find out why. And once we know the why, we actually treat it. We see the inflammation go down and see the disease stabilize. So when you get one of these tests, and if they do find plaque, understand that it's a treatable condition. but the first aspect is to find it. So the other element I want to just bring up, just so that you know, is that inflammation of of the body is the cause of plaque development. Inflammation is not only the cause of plaque development, but the cause of that plaque rupturing and you getting a clot to prove it. This is not new science. It's been around 160 years, roughly. Dr. Virchow basically published that inflammation is causal of atherosclerosis. So we do measure inflammatory markers routinely to look at the inflammation of this part of the artery called the endothelium, and to look at inflammation deep within the artery wall. Again, you may have to ask for those tests, and that's okay. Because what we want to do is make sure, do you have any inflammation here? Do you have any inflammation here that could allow one, plaque to develop, or two, plaque to jump out and get a clot? One of the best ways to keep our heart safe is to keep the arteries cool. It's a pretty simple analogy. So if you have inflammation driven by any source, you have risk of developing plaque in the arteries and you have risk of that plaque misbehaving. So does the standard of care do these simple tests I've been telling you about? Do they do that? No, they don't. The reality is standard of care is depicted oftentimes based on what your insurance carrier is going to pay for. Matter of fact, oftentimes, and I'm embarrassed to say this, but healthcare providers may not even offer you a coronary scan or a CIMT or vascular inflammatory testing. Why? Because they're going to assume you don't want to pay for it. They're going to assume because Primera, any insurance company may not pay for it, so they're going to assume you don't want to. And what I want you to realize is you are responsible for your care. A heart attack, if you live through it, is going to cost you and your insurance company about $500,000. The tests we're talking about cost $100, $30 for some of the lab tests, $200 for some of the structural testing. You may not have that much money, and I'm don't disrespect that amount of money, but you could, if you knew it was available, save for it and choose to spend it on this. And it's your choice. It's your body. And I like to use the analogy of our car insurance. The car insurance that we have does not pay us to check our oil, to check the tire pressure, to evaluate cracks in the windshield or weaknesses in the brakes. No, our insurance is used for catastrophe if we get in an accident. So really, I want you to kind of twist your mind a little bit around the world of insurance. Sadly, plaque or disease of the arteries is much smarter than the technology that's been historically designed to find it. So we need to be really our own advocate in this whole thing. Why is the current risk factor scoring system often misleading? When you go in for a physical, oftentimes they calculate something, and if you're laying there, sitting there, it seems fancy. Matter of fact, your healthcare provider may be on an iPad, and they're measuring things like your age, your gender, your smoking status, your total cholesterol, your blood pressure, and they're saying you're fine or you're not fine. What they're doing is doing something called a Framingham risk score, and it's what your insurance company demands that you get when you go in for a physical. And I have a secret, ladies. If your score is less than 7.5, if they say, well, you're low risk for a heart attack, that's a gamble, because this scoring system cannot tell you if you have plaque in the artery wall. This scoring system cannot tell you if you have genetics. This scoring system cannot tell you if you have vascular inflammation. And this is not a new thing. It's been challenged. Are we okay? Our risk factors might say yes. We might have normal cholesterol. We might have okay blood pressure. We may not smoke. And so the risk factors are going to say you're fine. But the problem is, oftentimes we're not. Matter of fact, this study was done looking at 222 adults who had a heart attack at a very young age. Women were under 65 years old and the men were under 55. The guidelines missed 82% of these women, these guidelines, the Framingham risk score, and they missed 66% of the men. So I say, look, it's time we stand up and we recognize that the standard of care is tenuous. If all we do is look at our risk factors and gamble like we're going to Vegas and say, well, I think I'm okay. You might not be okay. So, what my colleague, Dr. Brad Bale, and I did many, many years ago is establish a new paradigm. We said, how about we find out all we can about heart disease, and we're going to educate our patients about it, and we're going to talk to our patients about what causes a heart attack. Matter of fact, we're going to go look for disease. We're going to do testing that's safe and valid and reproducible and relatively cost effective to say, do you have plaque in the arteries? We're going to evaluate for inflammation in the arteries. We're going to look at root causes. We're going to set individualized goals for our patients, and we're going to use genetics as they're available. So it's a very different paradigm compared to the standard of care. However, we have proven with this paradigm with 2 large trials that you can regress and stabilize atherosclerosis. So I want you to leave this little section at the top optimistic, but it's your job to be your own advocate and say, I want this type of testing. So we talked about red flags, and red flags are things that, gosh, if you have those, you should get checked out. But what I want to talk about next, and I just want to mention it, there are things that are actual root causes. So root causes of vascular disease mean that if you have one of these, you do have a risk of developing plaque in the arteries. And so they're also treatable. So if you treat it, the risk goes down. That's the big difference. So it has a causality associated with it. And sadly, in Western medicine, really 2 elements that drive vascular inflammation and plaque development are the following. If you have high cholesterol and or high blood pressure, those are the 2 that are paid attention to. I want to just share with you how many root causes are published and have data to say if you have perfect cholesterol and perfect blood pressure, you could have many of these root causes that are going to drive vascular disease development and inflammation. So we've got obstructive sleep apnea or sleep disordered breathing. We have the genetically inherited lipid abnormality called lipoprotein A, which very famously was reported by Bob Harper, who was one of the trainers for The Biggest Loser and dropped of a major heart attack while he was working out in the gym. He's got a lipoprotein A problem, again, a treatable lipid abnormality, but it's normally not tested. And 24% of individuals carry it. Low vitamin D has been proven to be causal. Yes, high blood pressure matters. Yes, cholesterol matters. But you know what? So does periodontal disease. So do genetics. So does insulin resistance. So does dysfunctional HDL. Endodontic disease, which is decay of the teeth. Inflammatory diseases that we've discussed. Infectious diseases like influenza. So many people have died of influenza in Spokane County. It's strikingly scary. So yes, we advocate to avoid those, and we are advocates to get vaccinated against those deadly viruses. Psychosocial issues are very important. Depression, anxiety are causal of vascular inflammation. Myeloperoxidase, nicotine exposure of any kind, and even gut dysbiosis, which is being discussed now as an autoimmune disorder, is a real, all of these things play a role. So if you have these and you treat them, the vascular inflammation and disease is going to improve. If you have those and 1, don't know it, or 2, are not treated appropriately, the vascular disease development is going to continue. And that's one of the reasons recidivism is so problematic. So if you have a heart attack and they treat your blood pressure and your cholesterol and miss everything else I have on here, you're at risk and vulnerable to have another one. Okay, so what can we do now to reduce our risk of heart attack or stroke? Because I want to leave you with action items today, and I have about 15 minutes to do so. So what I created was a top 10 list. So 10 things I want you to take home out of this talk, and let's just go through them. So number 1 is education. Please, oh please, get educated. And so what I wanted to do is give you a resource that you can go to learn and review what we just discussed, and also to apply it more grandly to your personal health. Eleanor Roosevelt said, look, no one can make you feel inferior without your consent. So if you take this information into your healthcare provider and you're not supported in your concern, I would really ask you to come armed with information to say, no, this does matter, and I do want this. And tell me how much that costs, because maybe I'm going to choose to pay for it. And in our book called Beat the Heart Attack Gene, which you can get off of Amazon, and I'm really not self-promoting it. I did not self-publish this book. When I give it to patients, I buy it myself. So, but in this book, Brad and I really spent a lot of time going over data. And what we did in here is make it very readable and absorbable. And we told you, we wrote it to the public, number one, and we told you stories throughout the book so you had a relatable topic. As one example, I'm going to tell you about our dear friend Camille, who's in the book, and hopefully on this call. Camille has been a real thought leader in the world of heart disease and women. She's a tremendous advocate. But Camille's interesting in that she had had a physical. This is over 10 years ago, by the way. She's over 10 years post her heart attack, but she had had a physical, and the doctor did that fancy calculation, and the doctor told her, no, you have a less than 1% chance of having a heart attack. And it wasn't a few weeks later that she's going up a flight of stairs and she's feeling extremely short of breath and anxious. And she even toyed with the idea of, oh my gosh, maybe I'm having a heart attack. But she said, well, no, I couldn't, because I was just told I had a less than 1% chance. So she even second guessed herself, as she did with her colleagues when she went to work and told people about it. And even worse, when she did get herself into the emergency room, she had to sit and wait while other people were pulled back. And so what we did in the book is take beautiful individuals like Camille and share with you what their root causes were, and what we've done differently and how they've improved over time. So we wanted to put in their story so this was a very relatable condition to you. So even though the cover has a double helix and looks a little fancy, it's because we do support genetics, but it's very readable. The foreword was done by Larry King, and he said, look, we should all live as if we have the heart attack gene, because if we did assume we had it, perhaps we'd make some healthier choices throughout life. So I appreciated him saying that. He said a lot of other things too, but number one, get educated. And that means asking yourself, do you have vascular disease? Because I will tell you, you won't feel it until it misbehaves. So appreciate what I talked about, like getting a coronary scan, doing a carotid IMT, getting the information you need to know if you're walking around with dangerous plaque in the arteries. I would also ask you, do you know if you have vascular inflammation? Have you had tests to look for things like HSCRP, microalbumin, LPPLA2? Very affordable tests that are available to you. And if you haven't, then I would be asking for them. Understand if you have any of these root causes, and if you do, you want to get them treated. First, you need to get them identified, because lo and behold, if you identify the root cause, treat the root cause, you are going to see the inflammation go down, and you are going to see the plaque stabilize. It's a wonderful opportunity. Number two, move more. We all need to move more than we're currently moving, period. Physical activity is one of the best drugs we have to reduce vascular inflammation, period. So when we exercise, I want you to think a little more grand than just helping our waistline or helping us feel better. It's an anti-inflammatory drug for the wall of the artery, period. So it drives nitric oxide to the artery wall. It's a wonderful tool. And the other thing I want you to keep in mind, you don't have to go run a marathon to get exercise. Do you know that cardiovascular activity at just 22 minutes a day reduces your risk of a heart attack by around 14%? So we're not asking people to pick up an exercise routine and go for an hour-long run every day, but we are saying to our patients, look, you owe it to yourself and you owe it to me as part of your healthcare team that you're going to move 22 minutes a day at minimum. Now, 22 minutes a day isn't going to be enough to hit your weight goals probably and do that, but at minimum 7 days a week, 22 minutes for sure. Burning an extra 500 kilocalories per week will actually reduce the risk of developing diabetes by 6%, which is awesome. This study was done at University of Michigan, and I often relate it to not only our own family, but to everyone I have the ability to talk to. And they asked these students at University of Michigan who were mind you, like 18, 19 years old. They were students who chose to exercise. So they were the kids on campus who were walking or biking or doing some of the club teams and things like that. They weren't there on a sports scholarship. And they asked them an open-ended question. They said, hey, why do you exercise? The bias of the researchers were that they were going to say, well, I want to drink more beer on the weekends. I want to be skinnier. I want to be whatever. I want to meet people. Do you know that the number one response was unsolicited and open-ended was the following: because my parents did. So if our children grow up in a home that exercise is part of the lifestyle, there's a much, much statistically higher rate that they will continue that through their lifetime. Be an example to our children. Get in the water, take them, expose them to different activities, show them the gift of a life sport, something they could learn at age 3 and carry with them forever. And it can be anything as long as it's activity. Expose children to all types of exercise, because the rarity is any of us are going to become professional athletes, our children included. I hate to break it to all of us, but the reality is our goal as parents should be, and as aunts and uncles and grandparents should be, that our children lead a healthy lifestyle. And so expose them to all kinds of forms of exercise. Remember that when you are active, you are more healthy. And I also say life is short. Even if we live to be 100 years, I want you to do things that make you happy. So if you hate to run, for goodness sakes, don't run. If you enjoy walking, walk. If you like to swim, swim. If you like to do yoga, do yoga. All of it has statistical data to improve our health, heart health. You are active, you are healthy. Keep that in mind all the time. Number 3, lifestyle does matter. So don't let the scale scare you. Be creative. So it's important to weigh yourself. Certainly, you want to make sure that you're not gaining fluid weight. You want to be respectful of what the scale says, and realize that losing small amounts of weight usually is a very healthy thing to do. And by the way, it's a success if we can maintain our weight through our lifetime. It's normal in the United States, ladies, that humans gain 2 to 3 pounds a year from the time we're about 55 years old. And all of a sudden we get to be 70 and we're 20 pounds heavier, and we think, how on earth did that happen? So having a scale to be our own sort of gatekeeper is really important, but it's not the end all and be all. I do want to respect obesity trends in our lifetime, and you can see that the highest group that's going up is the obese group. It's just growing exponentially, and so is extreme obesity. So being overweight is pretty stagnant, which is good, but the obesity world from about 1980 to about the year 2000 just took a huge climb, and it's getting sort of flattened, but it's definitely on a linear trend up, especially the extreme obesity group. So yeah, we do need to respect weight gain. But what I want you to do today is get out a tape measure, and I want you to measure your waist. So to make it simple, just go above your hips and go to the thickest area of your waist, and I want you to measure it. It's usually around where the belly button is, but I want you to get that measurement. And ladies, no matter how tall or short we are, the color of our skin, any of that, we want to keep our waistlines less than 35 inches. If it's over 35 inches, you're at a significant increased risk for diabetes, metabolic syndrome, heart disease, high blood pressure, higher blood sugars. So you've got to work on your waistline. I really think waist measurements need to be measured more frequently. They are a vital sign, and it's just critical. So measure your waist and watch it closely. Huge fan from a lifestyle standpoint of mindfulness. Practicing mindfulness 15 minutes a day reduced things like chest pain, sleep quality and sleep efficacy, reduced anxiety and depression, reduced blood sugars and blood pressure. It was tremendous. Mindfulness is about being in the present moment. So we do advocate practicing mindfulness about 15 minutes a day. Music of your choice is a very important tool to provide nitric oxide to the artery wall and actually can increase blood flow by 26%. So music is beautiful, but it has to be one that you enjoy. Number 4, avoid all nicotine exposure of any kind, whether it's a patch, whether it's gum, whether it's vaping, whether it's cigarettes, whether it's secondhand smoke, avoid it. Nicotine exposure accelerates our risk as women of having a heart attack by at least 10 years. So it can shorten our lifespan dramatically, and it can affect our quality of life, and it really messes with the microvessel circulation. So women are at increased risk for things like dementia, kidney disease, peripheral vascular disease, and oh yes, heart attacks and strokes. So no nicotine at all is what I would advocate for. Number 5, know your numbers, know your blood pressure. This is normal, ladies, 115/75. When you start creeping up, so does death rate. So know your numbers and be very strict. When we look at blood pressure changes, what we've recognized is that blood pressures over the last 25 years are increasing. And they've even noticed that blood pressures over 110 are associated with cardiovascular disease. Heart disease and stroke accounted for the majority of disease burden of heart attack risk related to that top number, the systolic blood pressure of even over 110. When you look at your monitor, this is the systolic blood pressure. Both the systolic and the diastolic matter, but this one really is an easy gauge to say, hey, we need to lower that number. This was called the SPRINT trial, and they looked at when that top number, systolic blood pressure, was reduced just simply from 140 down to 120. There was a 33% reduction in primary cardiovascular events and a 25% reduction in all-cause death. So really, this should be less than 120 ideally. They have changed the guidelines for blood pressure, which is wonderful. In November of 2017 and really being pushed in 2018, they've lowered the guidelines now to say normal is less than 120/80. Elevated is anything above 129 or above 80. So if your blood pressure is 130/82, that's not okay. And high blood pressure is actually 130 to 140, over 80 to 90. And you can see how much stricter these guidelines are. So I really appreciate that they're pulling in the reins a little bit. Blood pressure is a very treatable condition. And if it's ignored, it damages the vessels, both small and large. Number 6, we walk into interesting cholesterol problems as we age, and I have about 4 minutes, so I'm just going to talk about this fairly quickly. But as we lose our own estrogen production, in other words, menopause, and we lose our body's ability to produce estrogen, the cholesterol starts to change. And what happens most prominently is the good cholesterol, called HDL, starts to fall. And the problem with that is the good cholesterol is actually protective. So oddly enough, what a lot of postmenopausal women need is more cholesterol. They just need more of the good stuff. And it's extremely protective of the brain. Matter of fact, when we start driving HDL levels up, stroke risk goes dramatically down, which is important. Even memory is affected by cholesterol as far as HDL. So if your HDL is under 40 versus greater than 60, you have a 53% chance of dealing with memory loss by the time you're 60 years old. So I like HDLs to be above 60, for sure, for sure. Number 7, pre-diabetes and diabetes. 7 out of 10 people who have plaque in the wall of their arteries have a condition called insulin resistance, otherwise known as pre-diabetes. Do you know it takes almost 20 years of being pre-diabetic before you're actually called a type 2 diabetic? And I'm not going to go into this. I know it's complex, but what I want to tell you, for 20 years of being pre-diabetic, all of this stuff is going on behind the scenes, and it's just damaging the arteries day after day after day. The symptoms you might notice of this, not a blood sugar problem, but high blood pressure, HDL, the good cholesterol falling, central weight gain, higher triglycerides, sleep problems, polycystic ovaries, cardiovascular events at a young age, When you see these things start to pop up on your own health history, you want to make sure that you don't have prediabetes. And how do you do that? Because you have to appreciate that prediabetes places you at a threefold increased risk of a stroke. It's not acceptable. So we advocate not waiting too long. Do not miss your chance. And there was a study published just today, and I did not do a slide on it, but looking at how the 3-month average, it's called the A1C, misses so many people who are in this condition. So we advocate for getting an oral glucose tolerance test. Take some sugar, it's done at the lab, and check your blood sugar at 1 hour and 2 hours. And it gives us a really good idea if you're somewhere on that continuum. But promise me, don't wait until you're diabetic to find out your insulin resistance, because your arteries are taking a hit from that. Number 8, see your dentist and hygienist regularly. We know that periodontal disease is not only associated with heart disease, but we have just published a paper showing causality. So we have shown that the bacteria that causes gum loss is causal of atherogenic changes. It can increase the amount of cholesterol in the blood. It can affect that artery wall lining to make it more vulnerable for the cholesterol to get through. And it also traps the cholesterol, breaks it down, and starts to aid in forming plaque formation. So we have patients understand this, and we work in partnership with the dentist and the hygienist, because we recognize that people who have periodontal disease have about a 4-fold increased risk of a heart attack and a 2-fold increased risk of stroke. So we ask our dentists and hygienists in partnership to look for the pathogens. Again, this is something that you can ask for. Number 9, and I'm almost done, I promise. Sleep is so important. So sleep is critical. 6 to 8 hours is the sweet spot, apparently, and so many people are dealing with disrupted sleep patterns due to animals on the bed, or significant others keeping them awake, or noise, or things like apnea or disrupted breathing. But if you're tired during the day, if you're getting up at night, if you feel you lack energy, you need to get a workup for sleep abnormalities, because it's important. And finally, number 10, please know that you matter. I want you to tell a friend of one thing you learned tonight. I want you to teach a friend something you learned tonight. And in that process, one by one by one, we can start to save a life. And I feel very empowered that you all are listening, because I think it's up to us as women to encourage education of our family, our friends, and our colleagues. So live strong, live educated, and please live well. I do respect the Go Red for Women campaign. I just feel that women often are left vulnerable because they don't know that this testing is available. So know that you're in charge of your healthcare, and it's your job then to be educated and be an advocate. So if you're a female and you have a family history of heart disease, and maybe the heart attack happened in your father, and they say, well, it happens in the men in our family. That's the biggest myth out there. So heart disease happens to women. It happens all the time. So 1 out of 3 of us is vulnerable to this. It's 10 times more frequent than cancer. So please understand that it's your job to become educated. Do the best you can until you know better. Then when you know better, simply do better. So tomorrow, make a choice to not drink that soda. Make a choice to practice mindfulness. Make a choice to know your blood pressure, to know your cholesterol, to know if you have any of these red flags. And then when you know that, do better. Ask for the right testing. Pay $100 to get a test to know if you have plaque in your arteries, even if your insurance company doesn't pay for it. Know your risk. Ask yourself, do you have disease? You're not going to feel it. You need to find it. Do you have vascular inflammation? And if you don't know, have you had the test to know? And why is that? What we need to understand is we need to appreciate the why of this disease. And with that knowledge, we can really make a difference in our own health. So I want to close just by thanking each of you for allowing me to share this information with you today. And I want to say, be strong. Laughter is super good for the arteries, and just be educated and be knowledgeable. So thank you all very, very much for your time.